You're sitting in a London clinic, 1889, your hands trembling beneath white gloves. The gas lamps flicker. The physician enters without looking at your face. He speaks in measured tones about your condition, something inside you that needs calming, realignment, therapeutic release. Within minutes, his hands are beneath your skirts, moving with clinical precision towards sensations you've never named. Your breath catches. He writes notes. And when it's over, when your body has betrayed you with a violent shudder of pleasure you didn't know existed, he schedules you for next Thursday. Same time. For months, Dr. Edmund Carter wasn't a predator. He was a respected physician. And what just happened wasn't assault, it was medicine. Standard care, reimbursable, recommended by colleagues at the finest medical schools in Europe. Tens of thousands of women received this treatment every week across Victorian England and America. Their husbands approved, their mothers recommended the practitioners, and every single person involved, physicians, patients, husbands, medical journals maintained with absolute conviction that nothing sexual was taking place. Because respectable women, according to Victorian medicine, had no sexual desires whatsoever. Before we go further, I need to know, where are you watching this from? The fact that people from every corner of the planet want to understand how an entire civilization convinced itself of something this absurd still amazes me. Drop your location in the comments. I'm genuinely curious. Now let's understand how the most educated men in the Western world spent 70 years giving millions of women orgasms while insisting, with perfectly straight faces, that female sexuality didn't exist. The diagnosis had a name: hysteria. And it didn't begin with the Victorians. The ancient Greeks created it. Hippocrates, the father of Western medicine, observed women suffering from anxiety, insomnia, irritability, trembling hands, difficulty breathing. He concluded their uterus was traveling, literally detaching from its moorings and wandering through the body cavity like a lost animal, pressing against organs, trapping nerves, causing chaos. The Greek word hystera meant womb. The condition belonged exclusively to women. The cure seemed obvious: marriage, pregnancy, satisfaction of the womb's reproductive purpose. Deny the uterus its function, and it would rebel. The woman would suffer. This wasn't cruelty. It was logic as ironclad as geometry. By the Renaissance, anatomists had dissected enough female cadavers to know the uterus didn't actually wander. It was anchored in place. The theory should have collapsed. Instead, they kept the diagnosis and simply changed the explanation. If it wasn't a traveling womb, it was something else, some inherent instability in the female reproductive system. The symptoms expanded to include almost anything a woman might report: nervousness, insomnia, loss of appetite, irritability, muscle spasms, sexual frigidity, and sexual forwardness. A woman could be hysterical for showing too much interest in sex or too little, for being too emotional or too cold. The condition became infinitely elastic, capable of absorbing any behavior that didn't fit the narrow parameters of respectable femininity. By 1850, physicians estimated that 1 in 4 women suffered from hysteria. 1 in 4, that's not a disease, that's the criminalization of the female experience itself. Victorian medical textbooks taught that women were fundamentally different creatures from men, more delicate, more nervous, organized entirely around reproductive capacity rather than intellectual or physical performance. The uterus was presented as the center of the female body. Everything else, the brain, the heart, the nervous system, was subordinate to it. Medical students learned that a woman's entire personality was tethered to her reproductive organs. Any deviation from her natural role as wife and mother would result in nervous collapse. Education was dangerous. Physical exertion was risky. Independence was pathological. Dr. William Acton, one of the most influential Victorian physicians, stated it plainly in 1857. The majority of women, happily for them, are not very much troubled with sexual feeling of any kind. This became doctrine. Respectable women had no sexual desires. They might tolerate conjugal relations as marital duty, But the idea that they could experience pleasure was medically impossible. A woman who admitted to sexual desire was unrespectable, probably hysterical, possibly dangerous. And yet millions of these supposedly asexual women were suffering. Their symptoms were real. The medical establishment acknowledged this. So they developed a treatment, pelvic massage. The theory was straightforward. If the uterus was causing nervous disturbance, then manual manipulation of the genital region would induce what they called a hysterical paroxysm, a sudden release that would calm the restless organ and restore the woman's health. The procedure was systematic. The woman would arrive at the clinic. She'd be led to an examination room and instructed to undress from the waist down while keeping her face and upper body covered. This detail matters. The face was covered so both parties could pretend this wasn't happening. The physician would prepare his oils, lavender, rose, sometimes plain mineral oil, and position himself between her legs. He would begin with broad strokes, gradually becoming more focused, more intense, working in circular motions, pressing deeper, finding sensitive points. The rooms were designed to maintain the clinical illusion: high ceilings, medical charts on the walls, instruments on nearby tables. Everything reinforced the pretense of medicine, and then it would happen. Her breathing would quicken. Muscles would contract involuntarily. Her back would arch. A sudden, violent release, what physicians meticulously documented as flushing, rapid respiration, copious secretions, profound muscular contractions, followed by deep relaxation. They were describing an orgasm, in clinical language, without ever using that word. Dr. Nathaniel Highmore, writing in 1660, documented the response with scientific precision: violent contraction and relaxation of the muscles, flushing of the face, sensation of heat, discharge of secretions, followed by profound relief and calm. Victorian physicians could read this description, perform this procedure dozens of times per week, and not recognize it as sexual response, because their entire medical education had erased female sexuality from existence. Anatomy textbooks showed male reproductive organs in elaborate detail, but treated female anatomy with remarkable vagueness. The clitoris was barely mentioned. Some texts called it vestigial, others omitted it entirely. Medical students graduated from prestigious institutions without ever learning that this structure had any functional purpose. They literally didn't know it existed in any meaningful way. By the 1880s, the demand had become overwhelming. Physicians were treating dozens of women per week, sometimes spending over an hour per patient. The work was exhausting. Dr. Russell Trugg complained in 1903 that achieving paroxysm could require 90 minutes of continuous manual stimulation, among the most tedious and exhausting of medical procedures. Read that again. A trained physician complaining about how physically tiring it was to manually bring women to orgasm. And he had no idea that's what he was describing. So they mechanized it. Dr. Joseph Mortimer Granville, a London physician suffering from hand strain, invented the electromechanical vibrator in 1883. The device could produce rapid vibrations at adjustable speeds, achieving in 10 minutes what previously required an hour of manual work. Why spend 90 minutes when a machine could do it in 10? The technology spread like wildfire. By 1900, dozens of companies manufactured vibrators. The 1906 Vice Company catalog offered over 20 models. They were handheld devices, floor models, vibrators built into furniture, specialized chairs with integrated mechanisms. The Chattanooga vibrator promised to relieve hysteria in under 10 minutes. The White Cross electric vibrator advertised the essence of life itself. And then something extraordinary happened. These medical devices entered the home. By 1900, the vibrator had become the fifth most common electrical appliance in American households, more widespread than electric irons or vacuum cleaners. Sears, Roebuck and Company advertised them in their general catalog alongside toasters and sewing machines. The 1908 Sears catalog described the home vibrator as very useful and satisfactory for home service. Women's magazines featured advertisements showing elegant ladies using vibrators with text proclaiming, Vibration is life. The secret of the ages discovered. Physicians estimated that 75% of American women suffered from hysteria. 75%. In major cities, certain doctors specialized exclusively in hysteria treatment and became wealthy. Appointment books filled months in advance. Some women appear in medical records with weekly appointments stretching across decades. Wealthy women arrange house calls. The most fashionable option was European hydrotherapy resorts, luxury spas where women received multiple treatments daily, powerful jets of pressurized water erected at their genitals while sitting in specially designed chairs. Bath. England became famous for its hysteria water treatments. Baden-Bach. Germany marketed itself as a center for female nervous restoration. The advertisements promised complete restoration of feminine vitality and renewed capacity for domestic duties. Of course, they felt restored. They were receiving regular orgasms in a society that insisted female sexual pleasure was impossible. Women recommended physicians to each other. Networks formed. Certain doctors became known for being particularly effective. Patient testimonials spoke of feeling invigorated beyond measure and experiencing remarkable return to cheerfulness. One Boston woman's letter explicitly recommends a physician's practice to a friend, noting that his treatments have a most remarkable effect on one's disposition. The women knew, at some level, they understood these appointments met a need they couldn't articulate. To name it would be to admit sexual desire, which meant becoming unrespectable, which meant the problem was them, not their uterus. The physicians had no idea at all. Dr. John Harvey Kellogg embodied the contradiction perfectly. He operated a large sanitarium treating hysteria with vibrators and electrical devices. Simultaneously, he crusaded against masturbation as moral evil, recommending clitoridectomy for girls who engaged in self-abuse and promoting male circumcision to make masturbation more difficult. He never connected the orgasms he was inducing medically with the sexual pleasure he was warning against. The same act performed by a physician was healing. Performed by a woman on herself was dangerous depravity. The distinction existed entirely in context and claimed intention. By 1915, American physicians were earning an estimated $18 million annually from hysteria treatments, roughly $450 million in today's currency. This wasn't fringe medicine. This was mainstream practice generating enormous profit. And then everything collapsed, almost overnight. The catalyst came from an unexpected direction. In the 1920s, early pornographic films, crude, illegal stag films circulating in underground venues began featuring women using vibrators for explicitly sexual purposes. The moment vibrators appeared in pornography, they were transformed. The device that had been respectable, medical, advertised in family magazines suddenly became associated with explicit sexuality. The dual nature that it had always been sexual, just disguised as medical, became impossible to deny. Within a few years, vibrators vanished from medical practice. Sears dropped them from catalogs by 1925. Medical journals stopped featuring them. Advertisements that had run for decades disappeared. Physicians quietly abandoned pelvic massage. The devices sitting in offices across the country were discreetly disposed of. What had been standard medical care became taboo overnight. Not because the practice changed, but because the context changed. Once the sexual nature became undeniable, the entire medical elastification collapsed. Hysteria itself survived as a formal diagnosis until 1952, when it was replaced by more specific terms like conversion disorder. But it never regained prominence. The diagnosis that had affected millions simply evaporated. The legacy, however, persisted. Women reporting medical concerns continued to be dismissed as hysterical. The term became shorthand for dismissing female experience, suggesting that women's complaints were emotional rather than real, subjective rather than valid. It wasn't until the 1960s that Masters and Johnson finally documented female sexual response with scientific rigor. They weren't discovering something new. They were documenting what had been happening in Victorian clinics for 70 years. What those studies confirmed was exactly what Victorian women knew, but couldn't say. The hysterical paroxysm was simply an orgasm. The response documented so meticulously the contractions, the flushing, the breathing, the release was textbook sexual response. If we take conservative estimates, 10% of adult women in major cities receiving treatment between 1850 and 1920, averaging 20 sessions each, were talking about tens of millions of medically administered orgasms. Possibly hundreds of millions. This wasn't marginal practice. This was mainstream medicine, touching enormous portions of the female population. Some women received treatment weekly for decades, some twice weekly. Some traveled to European spas for multiple daily treatments across weeks. The cumulative number of sexual experiences facilitated by a medical system that insisted women were incapable of such experiences is almost impossible to quantify. What's most striking is how everyone involved remained blind. These weren't incompetent practitioners. They were respected physicians trained at prestigious institutions, publishing in peer-reviewed journals, treating wealthy, educated patients. They had anatomical knowledge, years of training, first-hand experience with human bodies, yet they remained blind because the culture had constructed an elaborate framework of denial. Medical textbooks that omitted the clitoris, curricula that never mentioned female pleasure, professional terminology that allowed sexual acts to be described clinically, architectural arrangements that covered face, the sheet placement, the positioning that let everyone pretend nothing sexual was occurring. It was a conspiracy of silence where everyone actually believed what they were saying. The physicians genuinely thought they were treating disease. The patients, understanding intuitively but unable to articulate, couldn't say the forbidden words. Medical journals published detailed procedures without anyone speaking the truth. This history matters because it reveals something disturbing. Medical practice is immune to cultural bias. Scientific training doesn't protect against the assumptions of the society it exists within. Brilliant, educated, well-intentioned physicians can perform the same action thousands of times without recognizing its true nature. Somewhere in contemporary medicine, there are almost certainly equivalent blindnesses. Things happening regularly, discussed in professional literature, performed in reputable institutions that future generations will look back on with the same bewilderment we feel now. We probably can't see them. That's the nature of blindness, but they're there. The Victorian physicians weren't monsters. They were working within frameworks their culture constructed, following protocols their profession endorsed, acting on beliefs their education instilled, and yet they systematically misunderstood something they dealt with daily. The disturbing lesson isn't the specific details of what happened. It's the recognition that it could happen, that systems of knowledge practiced by educated people with genuine good intentions could be fundamentally mistaken, and that the mechanism maintaining this mistake was so elegant, so systematic. It took pornography, the most stigmatized form of media, to finally break through the denial. The irony is almost unbearable. Hysteria treatment was so embedded in denial that only pornography, the ultimate representation of taboo sexuality, was crude enough, explicit enough, undeniable enough to shatter the medical pretense. After the treatments ended, many women experienced what we might now recognize as loss. For years, perhaps decades, they'd received regular attention, experienced pleasure, found relief. Suddenly it stopped. Not because their condition was cured, there was no condition, but because society's willingness to maintain the pretense collapsed. The cultural amnesia was nearly total. Within a generation, the fact that physicians had routinely treated women with genital stimulation seemed unbelievable. Historical accounts expressed bewilderment that intelligent people could have engaged in such practice while maintaining it was medicine. Yet the women knew. They remembered. Some wrote about it later in guarded language. Others never spoke of it, carrying the memory throughout their lives, a private understanding of something the world insisted wasn't real. The next time someone dismisses a woman's complaint as hysteria or anxiety or just emotional, remember this. For 2 centuries, the medical profession gave women orgasms while maintaining that female sexuality didn't exist. They performed this treatment thousands of times daily without understanding what they were doing. Not through malice or stupidity, but through chosen ignorance, cultural blindness built into education, reinforced by consensus, protected by everyone's need to maintain the pretense. The vibrators that filled medical offices, purchased through catalogs, discussed at conferences, they all pointed to the same truth, but nobody wanted to see it. The cost of seeing would have been admitting women had sexuality, that the profession had been performing sexual acts for decades, that the fundamental framework for understanding women was based on false premises. So, instead, the history was erased. Within 50 years of the practice ending, it was nearly impossible to find in medical literature. Treated as an embarrassing footnote, something that happened to medicine in the past, but that modern medicine had moved beyond. What we're left with is an episode so counterintuitive it seems fabricated. That millions of women received explicitly sexual medical treatment, while everyone maintained female sexuality didn't exist, contradicts basic assumptions about how knowledgeable people behave. Yet it happened, for 70 years at peak, spanning continents, involving thousands of practitioners and millions of patients. Systematized, professionalized, marketed, discussed academically, performed in prestigious institutions. And almost nobody recognized what was actually occurring. The truth persisted anyway. Despite systematic efforts to deny and erase, the record remained. Women's memories, the devices themselves, medical journals and testimonials, all survived. And when culture shifted enough that the sexual nature could no longer be denied, the truth emerged. This persistence against systematic denial is perhaps the most encouraging aspect. No matter how comprehensive the attempt to erase reality, the evidence remains. The vibrators survived in museums, the journals remained in archives. The women passed down memories, even in coded language. History doesn't disappear because we refuse to acknowledge it, it waits. And when conditions change, when cultural context shifts enough, truth finally emerges into light. Reality doesn't wait for our permission to exist. Victorian physicians' inability to see what they were doing doesn't mean it wasn't happening. Everyone's insistence they were practicing medicine doesn't mean they weren't engaging in something sexual. The mechanisms that created Victorian medical blindness are still present in education, in professional culture, in human capacity for systematic denial. We have our own blind spots, things we can't see because culture hasn't shifted enough to let us. Truth waits, quiet, patient, persistent, enduring, ready to emerge the moment we're finally willing to see.